Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hi, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. Hopefully you had a good January. And now that we're at the end of the month, it's Terry Tuesday, which means it is Top 10 Tuesday. So today we're coming back to what we were doing a lot last year before we had a lot of breaking news. And you're going to get my top 10 coding questions and responses to those for the month. So some of them spilled over from last month as well. But boy, January with 2019 has been a very, very busy month. So I want to dive into coding, and hopefully you'll find one of your specialty questions in there, and a couple of little tidbits that some of you have sent me via email, or you contacted me on LinkedIn, or found me on Twitter, and I appreciate all of you. Thank you for the really kind words about the Codecast. I love the loyal listeners and all the feedback that we're getting that's really positive. So thank you very much. But first, today the Codecast podcast is brought to you by Movado Watch Company, one of the world's leading watchmakers. Movado, modern, ahead of its time. Movado.com. Also check out their new affiliate, MVMT Watches, at mvmtwatches.com. Okay, so let's get started on our coding questions. And we've had a couple that have been a bit challenging. So when we talk about some things with regard to documentation and billing claims that there may not be final documentation performed. And so a lot of the coders are saying, what do I do? Well, some of these things you would actually think, okay, well, that's common sense. But what we know as coding professionals is common sense, and maybe we know as the Holy Grail, I guess I should say. Sometimes we do have to take it back to the physicians and kind of bring them back to reality and say, here you go. This is what the rules say. And so you really can't do what you think, you think is correct when we have some rules that says that we can only do certain things within these guidelines. So here is a question that came out, and thank you to Pam in Florida. It said that the physician said, well, we had a problem and the administration has a question. So what happens when you're billing claims while documentation is still in draft status or not finalized? Well, one thing that you have to keep in mind here is that CMS is pretty specific. They say that you can't bill anything that you can't support. And so, documentation has to be complete before billing the service. Most practices give physicians anywhere from 14 to 21 days to finalize their note. But if the billing is going out the same day, the patient's being seen, and some of these are level 5 claims, then that documentation has to be complete or you have a serious compliance issue. So make sure you know that you have to do your documentation. There's not an option. It has to be documented, dictated, filled out, authenticated in the electronic medical record, if you're hopefully off paper charts, before you can submit your claim. You can't bill for something that you can't prove. And I say this a lot in my live seminars, and I think I've said it on podcasts before, but I don't want you to submit anything that not only can you not support, but also if you have to appeal it. Think about this. They have a claim dated, let's say, January 2nd. And so then they ask for records, and it was either forgotten or not done, or basically just not finalized by the physician. So you go to print a documented record and there's nothing there. Well, you're in big trouble. They're going to ask for a refund. But let's just say the doctor did the documentation, 10 days or 2 weeks after it was actually billed out. Well, all documentation has a transcribe date, usually at the bottom. And the payer is going to say, wait a minute, you billed this out and then you went ahead and documented it. And that could be a huge compliance issue. So in answer to this question regarding can you bill for services that have not had a finalization of the documentation, that would be no. You complete your documentation, you close it out, you sign the note, and then you can bill for it. If it's not documented, it's not done. That is the holy grail of making sure that you understand how things work in the coding field. So we have to be really cautious about that. So another question has come up recently, and I thought this was kind of interesting. This one was about assistant surgeons. So the question comes in, so Terry, we have a problem getting paid for our assistant surgeons. We put the 80 on the surgical code and we submit the claim, and on the op report, it shows that there's an assistant surgeon listed right under the regular surgeon or the surgeon of record. So how come we're not getting paid? Well, here is a policy that you may want to instill in your office, and I think some practices are not aware that this is part of the CMS provider coverage. So CMS and commercial payers provide coverage for assistant surgeons for many procedures, as we know, and an assistant surgeon is considered medically necessary when the complexity of the operation necessitates the primary surgeon to have additional skilled operative assistance from any of the following. So another surgeon, a licensed physician assistant, or a registered nurse first assistant. So in the Medicare physician fee schedule database, there's actually a policy outlined where on the physician Medicare fee schedule database, they have a policy outlined where they have indicators. So they designate surgical procedures as follows. So those where a surgery assistant may be paid, it would be an indicator 2. Those where documentation must be submitted to substantiate the medical necessity of an assistant surgeon is an indicator 0. Those where an assistant surgeon may not be paid would be an indicator 1, and those where the assistant surgeon concept does not apply is an indicator 9. So basically, this is what you want to do, and this is what it says right in the Medicare reimbursement policy manual. So basically, it says for indicator 1, designated procedures, providers need to document in their op report why an assistant is required for the surgery. If the chart notes are requested for review, that information must be documented. So the operative report should document with specificity the activities the assistant surgeon performed. A separate operative note by the assistant surgeon or specific documentation of their activities can be acceptable. That's not necessary if it's in the primary surgeon's report. So it can be in the primary surgeon's report, but they can't just say and list who's going to be assisting. So it has to say something like routine opening and or closing of the surgical site, performing post-operative monitoring. Intraoperative records have to clearly document that, the time the assistant was present in the operating room as well. Time in and time out time should be there. Otherwise, you're going to have a possible problem with certain factors of those indicators. Generally, assistant surgery are non-MD professionals like nurses, operating room technicians, or other specially trained professionals whose services are included in the primary surgeons or the facility's reimbursement. And so that's where you have to be very cautious where what isn't reimbursed. So activities performed by assistants in surgery may be passing instruments, but these are not separately reimbursed. So hands in the wound assistance, other general assistance that does not require the skill of an assistant surgeon. So those are basically things that you would not code for. But, necessitating the services of an assistant surgeon, what you do need, so if there's, any complicating patient characteristics, age, obesity, bleeding tendencies, immune statuses, cardiovascular status, or certain concurrent illnesses, but there's the need for a complex assistant, then you can get that paid. But it's more than just listing the name. You have to have some of the information that explains why you need an assistant surgery within the major report. So number 3 for our top 10 Tuesday would be Coumadin patients. So warfarin patients, patients who are on blood thinners or what we like to call anticoagulant therapy. So we had an update in 2018, and as I'm teaching cardiology classes all over the country and doing my updates also with webinars, I'm finding there was a miss last year where the 93793 code that says anticoagulant management for a patient taking warfarin must include review and interpretation of a new home, office, or lab international normalized ratio, that's the INR, test result, patient instructions, dosage adjustment as needed, and scheduling of the additional tests when performed. So this code itself is great because prior to 2018, you would be able to code the 85610 code, which is the lab portion of taking the blood draw or finger stick on a patient. And then only if there was a problem, and again, this is a face-to-face blood draw in your office, could you then code also a nurse visit 99211 if there were, extra questions or, maybe easy bruising on the arm or something that there was a problem. It couldn't just be to say, okay, you look great. But what's been nice is that Medicare and AMA got together and said, we need to have more regulatory services and basically more compliance on patients who are on blood thinners. And so whether they come into the office or not, whatever physician is managing those things and managing their pro times, they should be able to get some reimbursement. And so basically, you don't have to be in the office to bill that code. So an example would be patient comes in, they get a blood draw, 85610, and then so they did come into the office, and then you're going to give them their result and maybe adjust their medicine. You don't have to, but you do have to give them their test results and any instructions. That would be the 93793. But if the patient basically, let's say they went to an external lab or an outside lab and had it done, and then they were called later and told about their results and if they had to make a medicine adjustment, you can still bill the same code with the place of service office, but you're basically, because it's an office service and it has a general supervision on it, but the patient doesn't have to be there. So this is a great new service that you really need to look into. So again, that would be your 93793 code. Number 4 is a pretty straightforward coding question. And I do like those. I do have a couple of those this week where I don't have to go into a big explanation. So this one says, Terry, a condition where the heart's electrical impulses cannot reach the lower chambers of the heart. What is that? Well, what that's known as is complete or third degree heart block. And the code is I44.2. You might have also heard it called complication of an AV nodal ablation or arterioventricular block complete. So basically, this means that there's a failure of the atrial electrical impulses, the current, to go to the heart, and it just won't reboot. So that's basically what the heart will not work. Remember, when we're dealing with the electrophysiology side of the heart and the heart block, we're talking about the computer of the heart. And so that's what that's about. Okay, so then we have something called HCCs. And HCCs are considered hierarchy codes. So what that means is that your physicians, okay, so let me just kind of give you a kind of what a hierarchical condition category is. And I had a request from somebody that found me on LinkedIn, and Susan, how are you? And also Angela. Just want to make sure you know what we're going to do is we're going to have a webinar coming up. I'm going to do it in a 4-part series. And we're going to start it in March, so the March 12th, 13th, and then April 23rd and 24th. You really need to have this information, and I've noticed 2 companies are teaching something in this category. AHIMA is $2,000, and then when you get into MGMA, they're charging almost $2,500. And these are great companies, don't get me wrong, but I think that the affordability of that is going to be difficult. And so what I want to do is I want to bring it to you in the basic format. So for those of you that do not know what a hierarchical condition category is, you've heard it called HCC. This is a risk adjustment model originally designed to estimate future healthcare costs for patients. The Centers for Medicare and Medicaid, that's CMS, their model was initiated in 2004, but you're seeing it all the time now because it's increasingly prevalent as the environment shifts to value-based payment codes and models. So the hierarchical condition category relies heavily on ICD-10 coding to assign risk scores to each patient. So each HCC is mapped to an ICD-10 code, along with demographic factors such as age and gender. Insurance companies use this coding to assign patient a risk factor score. So you've seen it called an RAF. Using algorithms, insurances can use a patient's RAF score to predict costs. So for example, a patient with a few serious health conditions could be expected to have average medical costs for a given time. However, a patient with multiple chronic conditions would be expected to have higher healthcare utilization and costs. So why is this important and why do you need to know about it? Okay, well, your physicians, not only under MIPS and MACRA, pay bonuses, but there's also a weighted cost performance for your physician. And so hierarchical condition categories helps communicate patient complexity and paint a picture of the whole patient. So in addition to helping predict the healthcare resource utilization, these RAF scores are used to risk adjust quality and cost metrics. And so let me just give you an example. So let's say you had a 68-year-old patient with type 2 diabetes with no complications, hypertension, and a body mass index of 37.2. And that's what was put on the 99214 for the day. Well, E11.9, which is type 2 diabetes with no complications, has a 0 RAF score. I10, hypertension, 0. The BMI of 37.2, 0. So the total risk on that patient is 0. But let's now look at it from a reality expansion standpoint. And this is what I teach. A 68-year-old patient with type 2 diabetes with diabetic polyneuropathy, hypertension, morbid obesity with a BMI of 37.2, and a status post left below knee amputation. You've seen it called a BKA. So now, because the descriptors was exactly what the patient had and not just throwing out codes, I've got an E11.42 for type 2 diabetes with a diabetic polyneuropathy. That's a RAF score of 0.0368. The hypertension is still going to be I10. I've got nothing for that. But the morbid obesity with a BMI of 37.2 is going to have, with the E66.01 and the Z68.37 combined score, now you have the 0.365, and then the status post left total knee amputation is going to have a 0.779. So now we've got a total optimized risk number of 1.18.08. Okay, so we've just basically taken that patient from not having any risk factors to now having a huge risk factor. And now this calculation assigned point value is going to make a difference for the patient and how your physician could be paid. And also for HMO, especially Medicare replacement plans, they are looking at this risk adjustment factor program. So this is what we're going to bring to your attention. And so that's really what HCCs are, kind of in a nutshell. But I'm going to do a beginner's course. So take a look at my website. We'll have it up there for you hopefully by next week as far as the dates. And I just want you to understand what HCCs are and risk adjustments. I'm doing a really big audit right now for a practice. And not only am I auditing their records, but I'm confirming and looking at their risk adjustment scores and looking at their HCCs to make sure that they're optimizing that patient score, because otherwise that could be a factor later on when it comes to bonuses. Okay, so now we're going to look at number 7 is modifier 25. So let's take a look at our modifier 25. And this has come up recently too, when it talks about different modifiers and what can we use and should we be using a certain type of modifier for a patient. But the one thing that I want you to keep in mind is when you use a modifier, you have to make sure that you can support it. Otherwise, it could be overutilized and you might have a payer that is not going to be happy about it. So a question comes in, and this was from one of my New Mexico clients. And she says, can you append the modifier 25 to any CPT code? Well, the answer is no. You should only apply the modifier 25 to evaluation and management codes, so our E&M services. You can apply it to any E&M service that is a separate and significant service from another procedure or other service at the time of the encounter, but it's not part of the other service. So when you apply that 25 modifier, it has to be significant above and beyond the usual pre- and post-operative work. And that's right in the descriptor of the code. So for example, let's say you had a patient that presented to the ER with rectal bleeding, and the doctor determined that was really a GI bleed. So you didn't know if there was a correlation to start, and they decided to take them in for a colonoscopy. That could be billed with a 25 modifier. The next modifier I really wanted to look at was the 53 modifier. And I had a cardiology client that was interested, actually in Alaska, was interested to know how to use that 53 when they're trying to discontinue a procedure. So she says, due to extenuating circumstances, what does that mean? So let's say that you have a patient that the cardiologist attempted a stent. Okay, so let's say they're doing a stent. and the patient started experiencing maybe a hypertensive crisis. So the cardiologist had to discontinue the procedure because of the patient's well-being. So they were only able to complete, maybe 15 minutes into the procedure, and it really wasn't completed, but they had to discontinue. And so in this case, you can code according to what the physician attempted before discontinuing the procedure. And here they at least attempted to angioplasty, 92920. It'd be the 53 modifier, information modifier first, and then you want to put down what vessel were you actually trying to treat. So if it was the left anterior descending, LD, or the right coronary, it would be RC. But this also requires documentation. So submitting modifier 53 alone does not provide the payer with enough information, and so they may request supporting documentation. So just remember when you're doing that, there's some requests that are involved in part of that. So question number 9, this comes from one of my Ohio clients. A 7-year-old was playing on the monkey bars at a local park when he fell and partially dislocated his elbow. He came to our office and the provider gently moved the bone and ligament back into place. 4 days later, the patient came back complaining of the same problem and our provider performed the same procedure. How should we code this encounter? Okay, so your patient suffered an injury that is variously known as a pulled elbow or what they call a nursemaid elbow, though the more technical medical term for it is a radial head subluxation. So I don't want to scare anybody with some of those technical terms. But depending on how the elbow was affected, your diagnosis code would either be S53.031 with an extra digit, nurse's maid elbow, right elbow, or S53.032, you'll need an extra digit, left elbow. The 7th character, A, would be the initial visit. So that would indicate that you're treating them initially. So though that you're not required to per ICD-10 guidelines 20.A.1, I would also assign external cause codes for the encounter. That describes how and where it occurred. So in this scenario, you could add W09.2XXA, fall on or from jungle gym initial encounter, and Y92.830, public park as the place of occurrence of the external cause. Being careful not to sequence the external cause codes as the principal or first diagnosis code. Those are always going to be secondary. The procedure your provider performed involves supporting the patient's elbow with one hand while bending the arm upward, then turning the patient's palm with the elbow bent using the other hand. Sorry, folks. That's considered a closed treatment of a subluxation in a child, nursemaid elbow with manipulation. And so this is 24640. So in that one, now the second encounter, it's a little trickier to code, but your modifier choice will again be key. So this time you could append the modifier 58, so staged or related procedure or service by the same physician or other qualified healthcare professional during a post-op period. Because remember, these services have anywhere from 0 to 10 days on them, and this one actually has possibly even 90 days. And because this is a manipulation, this one does have a 90 days. And so you don't want to get bundled. But when you look at this one, you want to make sure that when you're coding it, that you understand it's a follow-up procedure to treat the original condition. And so you can bill for the second service using the same ICD-10 code, except now your 7th character is not going to be an A for initial visit. It's going to be a D, indicating this was a subsequent encounter. So understand your ICD-10 codes. That's really what's going to be your key there in making sure that's accurate. And then our number 10 question was, Terry, can you explain what bradycardia is? Bradycardia code R00.1, that's really easy. It means that the heart rate is too slow for a patient. You may have also heard it called slow heartbeat rate. And so that's what that code is for. Pretty easy definition. So those were our top 10 coding and billing questions for January. As we look forward into February podcasts, I'm going to do something about marketing your practice. So how to reintroduce yourself into the community and really what patients are looking for. I've been reviewing some of the payers' patient satisfaction surveys, and I'm telling you some of these top 10 questions they ask the patients and what the patients are responding to, you really want to know. You really do. And then after that, we'll go into first impressions of your office, waiting room aesthetics, reception areas, patient experience, and also, again, looking at that satisfaction survey. And we'll also get into the billing office as well. And I'm going to touch again on HCCs because I know that's what everybody really wants to talk about. And I will get into some different coding options as well. We want to look at, kind of get a little bit more heavy into coding and compliance as we get further into 2019. So my personal thing this week, well, I'm sure some of you know, my Steelers ended up second in the AFC North. And so with a 9-6-1 record, we did not make the playoffs. So I'm a little sad. I used to watch those over and over again, all the games of the year at night. And so right now I am rewatching at nighttime because I always like to watch something to fall asleep. I don't know if you ever heard of the show called The Practice, but it's an old American legal drama. Had 8 years, 8 seasons, and it's interesting because it's from 97 to 2004. If you've never seen it, or you're somebody that didn't, really watch things back then, I don't think we have a lot of good TV right now. Everything's a reality show. There's just not a lot of good things out there. I mean, I like Blue Bloods, and a couple of things, but even there, I miss the old Law and Orders. But if you get a chance on Netflix or anything like that, or even on TV, I think it's being replayed on FX. Try The Practice. I think you'll find it's kind of scary sometimes, but it's not as gory as like CSI and all of those shows. I don't need the gore. I just like the intrigue of the legal profession. So anyway, it's kind of exciting for me. But everybody, I hope you have a good rest of your month. And I hope everybody who watches football likes who's in the Super Bowl. And so we'll talk to you soon. Make it a great day. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.